Good evening and welcome back to part 2 of this 4-part webinar series, breakthrough series in introducing implants into your practice. For those of you that missed webinar 1, do not worry, please let us know and we'll send you the private link to our private YouTube space and channel, and you'll be able to review that and see webinar 1 too. You'll also get a link from here too. Also remember to fill out your feedback forms, which you'll be getting after this, to your emails, and once you've completed those, you'll get your free CPD. Get your friends and colleagues to follow us on social media so you know when the next webinar is coming up. If you're interested in the bootcamp, which will be following this 4-part series, which is a 2-day event with limited numbers, please do let us know as well, because it is first come, first serve. And if you'd like to come into the practice, please let us know. There's been overwhelming interest with that part of things. So if you could let us know as soon as possible, we can then slot you into sort of a time frame, and also know that patients will allow that, because obviously you have to ask their permission. A lot of you have asked which procedures I'm doing on particular weeks, and we're happy to disclose that and discuss that with you, because you may be coming in for a particular thing that you want to see, whether it's within your scope or where you want to go, or maybe you just want to have a chat. We welcome you, as we said last week. Without further ado, let's crack on and get into part 2. If you'll indulge me, I've had a number of requests asking one of the cases that I showed, what we actually did with that case. That was a bit more of a complex case, and not knowing the scope of the people attending this webinar today, because there's quite a number I can see, and I'm just going to talk to everybody as if we're all novices or all on the same level. This was more of a complex case, but no reason why it can't be discussed. So let's have a look and start with the webinar, shall we? Okay, so the case that we did see from last time was a case where the lady had come in wearing upper and lower dentures. You can see that she'd been missing teeth a while, and that there wasn't a lot of care being taken. This was the original X-ray. The reason we decided to treat this in the way that we did, one of the major things was the fact that with the lack of bone, particularly in the upper, and also lack of bone the lower, which respectively to the teeth doesn't look as if it's as bad as the top, but it is, because the lower teeth are foreshortened and have been worn down and heavily restored. We knew that restoring this would involve then prostheses that were exceptionally long, and not really what we wanted restoratively. So we knew that we would be using some pink gum to do this. Just going through it very quickly, where you can see that with the teeth that are there, most of them have a poor prognosis. The lower teeth had a large number of restorations. You've got periapical lesions, heavily restored teeth, widening of the lamina dura, you've got periodontal ligament, you've got caries on the upper, and pretty much the same thing as well as a failed root canal treatment, lack of teeth, bone resorption. There wasn't anything particular about anything else other than the position of the mental foramina were pretty much normal. The sinuses were slightly anterior, and there is some pneumatization, particularly on the patient's right. Once we just go through this, we'll go through into today's webinar, but I thought it'd be interesting because we had a number of people asking what happened there. We didn't see an end result. We saw this last week with, again, biotype 2, sort of an more of an oval bioform of the teeth, splinting, caries, some perio, splinting on that side, caries again, and similar on that side. Also a broken root, and I would say that the oral hygiene wasn't exactly wonderful. It shows a history of neglect to some extent, but we don't know why this has occurred. This may being cumulative after a traumatic event, or it may have been phobia or something along those lines. So without judging, we are just basically looking at what we see. There's also, looking at the next ones we discussed last time, had some raised lesions, probably wears denture at night because there's the early signs of denture stomatitis, and some denture stripping and rubbing. Those anterior teeth, you can see, other than radiographically, physically, you can also see that they have a fairly poor prognosis. They've splintered together, probably because they were moving. And to basically, as a last resort, just to patch things up. This patient did wear dentures. Just looking at the lower, which was in pretty much the same condition. And you can see the shortened teeth that we saw in the X-ray here. And we can also see the flattened ridges. The flattened ridges are usually a main cause that patients have problems with the bottom with dentures and then seek implant treatment. You can see the foreshortened teeth. And now you can see comparatively, there is actually a fair bit of bone loss, along with a retained root and heavy restorations in the anterior area. Okay, so as I said last time, the dentures sort of show us a good indication, a clue as to how much tissue is missing, because pink is replacing bone and gum in that area. And they also show you whether or not the patient's been keeping the dentures clean. In the situation, the dentures are pretty clean. Not completely, the lower one does have a bit of a buildup, but in comparison to the teeth, much better. Okay, so going back to what we had, we decided the fact that we'd treat this in a full mouth rehabilitation sort of way, popularly known as, all on four, or whatever you like to call it. Pretty much sort of the same strategy. So we decided that with the amount of space and bone that this patient had, that we would place 4 upper implants and 4 lower, the 2 distal in each arch being angled, and the 2 in the center being straight for distribution of anterior posterior of the forces. This is a radiograph taken immediately after surgery. Apologies about the focus of the lower, but because of the focal trough, she's sort of almost sort of a class 2. We weren't able to get those both in the same visual field. These were placed, when we do this procedure, we place the front 2 implants approximately where the laterals are, upper and lower. And the posterior implants we want coming out at an angle as far back as possible, really. We angled these at about 30 degrees. So these would have come out round about sort of the premolar or molar. And we're intending to place bridges that only go from 6 to 6 in each jaw to compensate for the 30 degrees angle and to realign those multi-units. They're the connectors that are on top of the implants. We use 30-degree ones at the end so that they're straight again and it has the same path of insertion. These were her provisionals. I intentionally like small imperfections, in the setup. I think it gives far more of a natural feel rather than a blocky feel. We went for a sort of longer oval shaped tooth, which was quite feminine for this patient. And we're fairly pleased with the end result. She's still, as you can see in this picture, I think this one was probably about a couple of weeks post-surgery. So she still has her provisionals in, and there's still evidence of angular colitis at the corners of her mouth sores from the lack of vertical dimension from her dentures, which she originally had. And that was a close-up from there. Okay. I hope that satisfies the people that were asking what happened with that case. Let's go into the actual webinar now. Okay, we'll run over just a quick overview of what we discussed last time. And we said, we want to get a breakdown in particular important parts. Also, for the people that have given back feedback form, you'll get your CPD, but also accompanying that, I hope you had contact via email. You can always contact us via email. There's a bundle of templates. We put together some really nice templates in order for you for the first part of the webinar. So you can follow those incrementally so that you can see which cases treat, not treat, etc. There's also an extensive bit on consent, and I've given you an example of one of my consents and what I would write, because putting into context is everything. Okay, so as we said last time, you need dental history, previous dental care, reasons for tooth loss, that is important, a history of treated periodontitis for obvious reasons. We need to make sure that the patient is stabilized, or at least is able to look after the final prosthesis to an acceptable standard. And this can be even a single implant. If you find the patient's got perio and you've treated them during perio, you would be, if you're brought up in front of dental counsel or a lawyer, as to why you did not eradicate disease. And that goes down to basic dentistry, where we get rid of all disease, get rid of the teeth that are terminal, perioral lesions that cannot be treated, root canal otherwise, periodontal disease, caries, anything else, and then we would move into structural. The structural part obviously is usually overlaps with the aesthetic, so therefore the two pretty much come together. Oral hygiene habits, important. Financial capability, need to know whether the patient can afford this. Is no good in creating these fancy treatment plans, and some patients may take them up and make life very hard for themselves outside practice, and that's not what it's about. We need to be looking after the patient in practice, and making sure that they have a better life, not a worse one, because they're trying to pay for their teeth. Genetic predisposition for tooth loss, habits, parafunctional activity we discussed last time. Motivation and compliance, very important. Patients motivated to invest time and money to oral health. Sometimes they don't come in like that, and there is a process of education and assessment that allow you to get to that point. And frequency of oral hygiene procedures. Okay. The examination, clinical examination, radiographic examination, and additional investigations. This is basically, we're going to be looking at things from a point of planning, treatment planning for implants. We've done the basics of seeing what the medical history and everything else behind that's like. We have consent or the consent process, but you need to have a treatment plan and diagnosis. So we're going to go through that today. I will also be talking towards the end about platform switching and emergence profile, two concepts I've put in fairly simple form that are important to grasp at this level. And remember, this 4-part series is designed to take on the basics. And as you develop those basics, you get more and more complex cases, which allows you to then investigate and take on more information, and thereby learning more and more and being able to deal with more and more complex cases. A much better way of doing it than throwing everything at you at once. Okay, so as I said last time, I want people to start looking at things a little bit differently. Don't just see a mouth and just see, I see some front teeth and there's a few back teeth missing. What do you see? Okay, what is the bioform? What is the shape of the teeth? Is it oval? Is it square? Is it rectangular? Wear on the teeth? Is there wear? There's lateral wear. There's some translucent through the tips from wear. The upper right canine looks darkened. Is that tooth vital? The patient probably has a biotype 2. Their posterior missing teeth. What does that mean? Are they wearing a denture? Has a deep overbite? Are they posturing? Is there stability? I can vaguely see through that blur some decoronated teeth and some caries, root caries as well. So when you start just looking at things a little bit differently, so you see a picture and you should be able to say quite a lot about it. I can also see some recession as well, and I can see some mild gingival inflammation around those anterior teeth. Maybe that's an indication that the patient cannot take care of teeth that are easy to brush and clean at the front of the mouth. Maybe there's another reason. There may be gingerly approaching class or things that are retaining plaque around them. So it's investigation. Okay. So I was asked in particular a list, and again, as I said, this next set of templates will have all of this in here, but I was asked last time, so I've added this particular slide as to could we have a list of exactly what should be in our notes, an exhaustive list that basically covers everything medical, legally, and otherwise in forms of making a treatment plan. So I have gone through that today. And put that together, right? These parameters should be addressed through a diagnosis and treatment plan. Treatment without diagnosis is commonly known as malpractice. So I would strongly suggest, as I said last time, you go back to diagnosis. And look, I'm not perfect. As I said, I'm not anything special. I've just been doing this a long time. If you repeat things many times, I think you eventually get better at them. So that's probably the only difference between myself and other people, or some people. However, you know, I've made the mistake of not making a firm diagnosis in the past. I've overlooked it, and you know, that's when things go wrong. And as I said, we put together also here, boot camp, and everywhere else I teach. I like to teach from mistakes I've made. I'm quite transparent. I like people to be able to see, look, you know, that's what I did. I don't want you to do, and this is how you can avoid it. This is the problem. This is a worry. This is a solution. Okay, we're going to talk more about that. And as I said, we'll go into that more. The external and intraoral hard and soft tissues, swelling or lesions, asymmetries, palpation of lymph nodes. How many of you still palpate lymph nodes? Head and neck musculature, temporomandibular joint. Okay, temporomandibular joint, very important. You know, look for crepitus and clicking. You know, find out what that means. Is it one side, both sides? Oral hygiene status, very important. Dental, periodontal, and restorative condition of remaining teeth. That's how we're going to say whether or not we can justify taking certain teeth out, like you saw in that first case, and that's why the reason I put that up there again. You know, we need to talk about caries, the vitality of teeth, tooth misalignment, fractures, attrition, abrasion, fraction, periodontal status, probing, pocket depth, mobility, bleeding on probing, furcation involvements. Now, depending on whatever you use, most people CPIT, MPROB, or a BPE. If you're having some of the higher figures like a BPE 4, you should really then go in and do a full 6-point probing chart. If you're getting 1s and 2s and the patient really has nothing beyond that, then you really don't need to do that. But always check for mobility and furcation involvements too. Because although there may not be pocket depth, there may be a history of periodontal disease, so they've lost the bone. They don't have pockets anymore, but you may have those furcation involvements and some mobility. Occlusion and function, the vertical dimension of occlusion. Maxillomandibular relationships, angles classification, basically. Overbite, overject, centric relation, sliding centric, lateral and anterior excursive contacts. Are they canine guidance? Are they group function? Is there anterior guidance? Signs and symptoms of temporomandibular joint disorders. In some of the smaller courses, particularly boot camp, we go quite extensively into occlusion. It's very, very important, but the type of occlusion I teach is universal. It's not just to do with implants. There's some tweaks with implants. Because ultimately it's the physics of dentistry. And if you don't understand the physics, I don't really know how you can understand performing dentistry so that things last and things are in harmony. Okay. So getting more into this particular webinar, a 3-dimensional space assessment and evaluation of the condition of the adjacent teeth and the surrounding hard and soft tissues. Whoops, sorry, I beg your pardon. Is necessary for provisional diagnosis. There are 4 parameters to consider. So, you know, I mean, these are fairly obvious, but obvious probably to me, and sometimes I have to think about it as if I was a novice learning. So if there's anything you don't understand or you have any questions, please do ask. There's a QA button at the bottom of your Zoom. You can easily ask them that. I will try and answer as many questions as I can at the end, but we have a limited time. And anything I don't answer, please feel free to email me. I'm more than happy to pick up the phone and discuss with you. Even if it's something you're not placing implants, you just want to learn a bit more about it, or I can always send you links or papers to support it. Okay, interproximal distance of bone. That's very important. We need to know how much space we have. At the moment in this webinar, I'm simply going to be talking about single teeth. When we come to placing more than one implant in a space, so shortened gaps or sort of larger full mouth rehabilitations, there's other rules, but I want to keep this simple. The buccolingual or buccopalatal width of the bone, the minimum vertical mouth opening and interocclusal distance. This is important, interocclusal distance, obviously, but also the minimal vertical mouth opening. We've had cases where it looks like an ideal patient. They have perfect quantity and quality of bone. Tissue's great, loads of keratinized tissue. They haven't had much bone loss. There's no occlusal, there's no real disease present. And then I've tried to go in there and there just isn't enough space for me to get, as it were, the machinery in there so that I can actually create an osteotomy or place an implant. I can't get a handpiece in there with the length of drill in there. So, you know, that is more important than you think. Soft tissue condition in the edentulous ridge area. And we're going to be going through all of these so you understand them simply and fully. Really, they're not that complex. It's sometimes just made to be complex. Okay. So the interproximal distance of bone. Basically, the distance that you require between an implant and a tooth is 1.5 millimeters. I don't know about you, but I definitely can't measure 1.5 millimeters. If you can, you're a better person than I am. So usually we try and round this off as being 2 millimeters because that's easier to measure in those spaces. That is the distance you need from an implant to a tooth. So for it to be successful, just so you know, between implants, you need 3 millimeters. So for a gap like this, which we'll go just into now, and I can go through and show you, you would need the diameter of the implant plus roughly 2 millimeters each side. So for example, if that implant was a 4 millimeter diameter and you need 2 millimeters each side, you need 8 millimeters for that implant. Now you can reduce the diameter of the implant to fit into a smaller space, but then you also have to consider the implant diameter versus the tooth you're trying to replace. For example, if I'm trying to replace anything, I tend to use a 4 mil implant. I'll go into the implants I use later. And look, there are other implants. As I said, Straumann very kindly support a number of our courses, and particularly the master's certification and diploma, but also the boot camp and a lot of the other things. So when you see things come up here, there's Straumann, it's not because I'm just spouting Straumann or I'm their poster boy. I actually use their products and I like them. So that's why I talk about them. I have no real vested gain for doing that. I get nothing back. So if there are other things you want to use, please obviously do. There are millions of companies, well, thousands of companies and implants out there. But for this particular one, I would usually use a 4 mil diameter implant. Just for those who want to know, I use the BLX system, which is not one I sort of recommend for people starting out in implants. I usually recommend the BLT, mainly because the BLX is far more aggressive, which I like in my hands. I think I get great success out of it. At the moment, just looking at this year's success rate, we're in the sort of 98% or so, which is in line with what it should be, between 95 and 98%. But the BLT implant is what I usually recommend, Straumann's BLT implant for people beginning, and that will take you right up to being intermediate. And some of my colleagues who are advanced or more advanced than me still use it, and it's less aggressive, so it tends to go down the hole that you drilled, the osteotomy. So with a 4 mil implant, I'll pretty much, if I can place it everywhere, I will. because it will support a molar, a premolar, a canine incisors, but quite often in the incisor region, that other than the central incisor, upper centrals, it tends to be too big. So in that situation, if you had a shortened gap here, you could use a 3.75, that's the other BLX, or the BLTs then go down to a 3.3 and down to a 2.9. So tomorrow I'm placing for a patient 2.9 millimeter implants for the lower laterals, so the 4.2 and the 3.2. And I'm placing one additional implant in that gap, but there aren't enough space for 4 incisors or 4 implants. And the width of bone will only give us that with 1 millimeter each side, as we discussed. And we're bridging the gap. Okay, so as I said, roughly 2 millimeter side, and then the endosteal diameter of the actual implant. The one you see here is Straumann's tissue level, which is quite a well-known implant and a staple for most implant surgeons. Most of us love placing this in the posterior region. Very easy implant to restore, actually quite a treat to restore as well. Okay. So saying the buccolingual or buccopalatal width of bone. It's a restorative delivery and orofacial implant position and access important in planning for implant-supported restorations. What does that mean? Okay, what is that? Okay, we basically, if you're, I'll just say for a lower implant, because then it makes sense. You plan from the top down and build from the bottom up. And what that means is that you want to plan where your crown is going to go in the occlusion, the size of the crown, and its approximation to the teeth either side, and then place the implant below it. If you don't have bone in that region, then you may want to graft bone, or you may have the liberty of placing the implant at a slightly angled inclination and correcting that inclination. So if you wanted it straight, but you're having to place it a slight angulation, I think you can probably go up to about 15 degrees now, you can straighten that in the actual abutment that connects to it. So you no longer have to go this way, it will straighten it and receive the crown on top. To do this, you need to assess the contour of the ridge. Okay, which you can do by palpation, but nobody does that anymore. You know, my recommendation, I am going to go through old school, because look, not everybody has access to CBCT or has one in their practice, or sometimes it can be quite difficult sending the patient to go and have one. They don't want to pay for one, etc. They may not be motivated at that point. So, you know, there are other ways of doing it, and I'll talk about that in a moment. Visually evaluating the available orofacial space for an implant, so that's very easy to do, and be aware of presence of concavities, lingual and or buccal undercuts. If you've got CBCT, you can see these, but in this area, I would sort of palpate, and I always do, to see, because they're usually disguised, especially sort of in the sulcal area and anteriorly, where you tend to get them a lot, and you need to sort of know what you're dealing with there. But the buccolingual, buccopalatal bone wall must be at least 1 millimeter thick to ensure stable, hard, and soft tissue conditions. Now, when I was taught, it was always 2 millimeters. And to be honest, I still try and stick to 2 millimeters. However, 1 millimeter is sufficient in most situations. Okay. So that's a 1 mil either side of the implant. And the way that I want you to imagine this is, imagine it as if it were, as if there was a barrel of bone around the implant. So ultimately you want to have at least 1 millimeter barrel of bone. Ideally, as a beginner, I would probably say 2 millimeters, just to be yourself safe. Okay, the minimum vertical opening should be around 30 millimeters is required for access. Straumann have this thing called this diagnostic T, which is quite useful, particularly if you're a novice, to see whether or not there is space. It also allows you to measure space for restorations, an average restoration, whether it's screw retained, cement retained, the 7 millimeters for cement retained and the 4 millimeters for screw retained, and multiple other things you can measure with it. And I think it's fairly inexpensive. Please don't quote me. I think it's a couple of $100 or so. The space requirements depend on the design of the restoration, including selection of abutments and crowns. So although we recommend that you discuss that with your dental technician, and that's quite important. Get a good relationship with dental technician. They deal with this all the time. You will learn a lot of things. So your treatment planning in order to have a restoratively driven orofacial implant position and access, as I said, building from the top up, planning from the top, building from the bottom up. The presence of overruption of the opposing dentition or the presence of cross bites can reduce the space available for the final restoration. This is important for you to check, especially with excursions, because although you look like you've got the space, when people having a cross bite or overruption, you suddenly find overruption being more obvious because you can see it when the patient bites together. But the crossbite, not as much so until you check their lateral excursion. So that's just as important. Okay. If the available space is insufficient due to overruption of the opposing teeth, depending on the extent of available space, you can use minimal enamelloplasty, orthodontic intervention, elective endodontics. I don't know how many people would actually sign up for that. I would probably do that. I think I'd be in hot water. If something went wrong, what if the RCT goes west and then you have to remove that and replace an implant? I'm sure the patient will be looking at you to replace that. Crown lengthening, yes. And crowning the opposing. If there's minimal and it's heavily restored and it's minimal overruption, you can crown the tooth and move it back. In such restorative cases should be handled only by clinicians who are experienced in treating advanced or complex cases. Look, to some extent, but I don't think so. A lot of these cases can be treated simply with a bit of advice and knowing what to do, but they are all individual. So if you have something you want to treat and you just want to get some advice before you treat it, please let us know. Start using this as sort of an information center, a place to go to. We're happy to help. And as I keep saying, as I said last time, we're more than happy to see you at the practice. Okay, the soft tissue condition, the edentulous area. This is also important. Soft tissue is important because we need to know what type of biotype it is, because different biotypes react in different ways. The tissue biotypes are classified according to how thick or thin the supporting bone and gingival soft tissues are. The health, form, and metrics of gingival biotypes can be assessed by using a periodontal probe. Completely true, and also by looking at it. Compared to the thin gingival biotype, the thick gingival biotype characteristics are, this is what we know as a biotype 2. The thin is a biotype 1, but there is a 1.5. When you look at it, you can't really say whether it's 1 or 2, okay? One you will find is prone to recession. So people with a biotype 1, if they have any peri, you tend to see have quite severe recession. Biotype 2 patients tend not to have as much recession. They tend to have pockets because that sort of like rough, tough tissue doesn't tend to move. It's not as sensitive to recession. But anyway, compared to the thin gingival biotype, the thick gingival biotype characteristics are thicker tissues, periodontal probe is not visible, so that's what I was saying, broader band of attacked gingiva, less scalloped gingiva, okay? Why is that important? If you're restoring an implant, what happens, a tooth with an implant, let's say a single, once you remove the tooth, there's no real known way at the moment of maintaining the papillae or the bone in the papillae area between the teeth. Usually we're mimicking that using soft tissue, we're using emergence profiles and things to mimic that. The less scalloped that gingiva is, the easier it is then to restore that. Very long, pointy scalloped gingivae and papillae, much harder to deal with. Easy to manipulate, provides a more predictable aesthetic outcome because it doesn't tend to move or shrink or run away, and more resistant to recession. Okay, that's what it looks like. Sort of like when I was learning many decades ago when I was an undergraduate, it's described, I don't know if it still is, as stippling and sort of like the skin of an orange. And I suppose you can see that really. Okay, thin gingival biotype, reduced soft tissue thickness, periodontal probe is visible, highly scalloped gingival architecture, more prone to soft tissue recession and buccal plate resorption. Buccal plate, the outer plate, is important because that's why a lot of cases they try and tell you not to raise the flap on that side, because the actual, or to lose the buccal plate, the blood supply to that side really does affect the amount of resorption that occurs and the amount of perfusion and blood supply you're getting to the area for osseointegration. You obviously want to preserve the buccal plate. I'm a firm believer in that, but sometimes you don't have the choice of not raising your flap, particularly if you've assessed it and you see there's a large concavity there, and you may have exposure in the implant that you need to deal with bone grafting or to check that you don't have that dehiscence. Okay. That is a biotype 1, shiny, thin, tends to be a bit more translucent, seeing through it. Okay. Radiographic planning. The vertical bone availability determines the maximum allowable length of the implant, and that can be placed and can be assessed on a radiographic image. Look, quite often they say place the longest and widest implant you can. I'm not a firm believer in that. You place implants according to the occlusal load and needs. Being more invasive is not always good. Bigger and longer is not always better. Outline important landmarks. Okay, the periapical panoramic radiograph using a transparent foil or paper and a pencil. You know, still you can go back to that. Quite often people bring in OPGs to me that are film. We still take a picture of those on a light box or just holding them up, and I will then print that and annotate on it when you scribble on it with a pen. You need to check also for anatomical structures when determining available bone height. Outline important landmarks on the radiographs. Inclination, oops, sorry, I think something happened there. Okay. So, inclination condition of the adjacent roots. That's important. So quite often people are saying that you want axial loading, that's down the implant, but if the roots are angled, like in this picture here, you want to place the implant parallel to those roots. You don't want to try and upright it. You're either going to go through a root or it's really not going to have the same occlusal plane as the other teeth. Convergent adjacent roots may compromise available interproximal space. Respect this root anatomy to avoid injury or interference during implant placement. Injury of adjacent teeth during implant placement can result in root canal treatment and or damage to the root that leads to further tooth loss. Now, although this isn't great, it can happen. If you put it into the consent, you warn the patient of it, particularly when you've got a tight space like this, which I wouldn't recommend a beginner to really approach or to start with. And you've taken all the necessary precautions. So if you were going to do this, you'd probably get a guide done. You would drill a pilot hole and then put a guide pin in and take an x-ray to see that you're in the right position, etc. And we'll be going through this in the next seminar where we go through drilling protocols. Consider the anatomical shape of the adjacent tooth roots. Note the proximity of this implant to the mesial root of the molar. It is very close. Okay, and we're not talking about the body of the implant by itself, but also the thread or the ferrule. I don't think this is super close, but it's pretty much getting to the border of just under 1.5 millimeters. Ideally, we would want this moved along at least another millimeter or so mesially. As you can see, there's probably about a good 3 mil on the mesial. It's the curve of the root, so you can see how it curves out that mesial root. And at the top, you've probably got that 1.5 millimeters, but as you get further down and that mesiolingual and mesiobuccal root bulges forward, you've got less than that. You need to be aware of that. Okay. Landmarks in the maxilla, such as sinus 4. A safe distance is 2 millimeters recommended from the floor of the sinus to the apex of the implant. Have I placed implants much closer or right to the sinus? Yes, I have. Sometimes when it's like that, we need to, we will use tenting, or what's known as a transalveolar approach, where we basically are tenting the membrane but through the osteotomy that we've drilled for the implant. Alternatively, if we assess these cases properly in advance, we then give the patient also the possibility of having a sinus lift. In this case, there's no need, there's plenty of space. That's probably about an 8 mil implant. And although it looks like a couple of mil to the sinus, it's not, it's probably about 4 mil. So they've probably got about 12 millimeters from the crestal surface to the sinus. Okay, users are advised to treat straightforward cases only. If the minimum distance of bone is not available, the patient should be referred to a clinician with adequate training experience in sinus wall elevation procedures. That is true. There's no real way around that. Note the proximity of the sinus floor to the apex. Oh, sorry, we're having a few problems today. I don't know what's going on. Let's go back again. Seems to be being a bit jumpy. Maintain a minimum safety distance 2 mm from the implant to maxillary sinus floor. That's what I would recommend. But even if you're about 2 mm from it, as a novice, I probably would suggest that you don't take those cases on, or you don't prefer that completely. Sometimes we get cases like this where I will augment the other way, bone graft, and give the dentist plenty of space so they can then place a longer implant without being close to the sinus and turn something that's complex into a simple case again and return it back to the dentist. Okay, landmarks of the mandible: inferior alveolar nerve, mental foramen, submandibular fossa and concavity, and there's a safety of 2 millimeters of bone between the apex of the implant and the neurovascular structure should be respected. I usually try and maintain a bit more than that. In cases, complex cases, so you just know, if I'm getting towards 2 millimeters, I tend to use a piezo with piezo frequency to at a particular setting to create my osteotomy or the end of my osteotomy towards the nerve. And if I'm getting close, that will pretty much tell me or stop straight away. You've got to also consider the loss of bone height due to ridge flattening as well during surgery. And you can see they've marked them here in pencil. You know, even if you don't have a CBCT, I strongly recommend you try and send patients CBCT, and don't try, and I wouldn't really place an implant without it now. And also it allows you to learn, and I'll show you how in a moment. Okay, the interproximal distance of bone as well, and the bone height. At the crestal bone level, the interradicular space, and pay attention to the interproximal. Sorry. Pay attention to the interproximal distance of bone at the bone level. Okay, here you can see that the root has been taken out, and you can see the bone height there. Okay, measure the available vertical bone height and select the appropriate implant type. This can be done with the help of the Straumann X-ray reference sphere, X-ray templates for Straumann, and also use of CBCT with planning software. And I'll sort of show you that. And this is quite a good way. And this is how I think a lot of dentists should get started, is to basically start planning cases that they're not going to even do. If you see a patient with a missing tooth and say they coincidentally, don't send them for a CBCT so you can have a practice. But if they think about getting an implant, there's no reason, there's an indication for it, or they've had one, then why not have a look, okay? And I'll show you some of the software you can use as well. This is basically by Straumann, and what this does, if you see the spheres, as you see 1.4 to 1, 1.5 to 1, with the Straumann sphere that you order from them, fairly inexpensive, you actually put that, you can even put it into some wax that's been pushed into the space and pop the sphere into that, and then take an X-ray, even a PA. If you just want to assess, I still recommend that you need a 3-dimensional X-ray to plan properly, but just as a starter to basically start planning, that will give you, if you then take the sphere and measure it on the X-ray, it will give you a number of spheres. And once you match it to the one you have, so if it's a 1.5 to 1, it's 1.5 times bigger. So you've measured it at 7.5 millimeters diameter, as you can see on that. That will then give you a guide for every implant as to the real length or the real amount of bone. So it's a calibration device. You also have to remember, with most implant systems, including Straumann, if you look right at the bottom, they do drill to about 0.5 mil longer than the actual implant that you're placing. So be careful of that with vital structures. The other way you can do it is, one of the softwares that I tend to use is Co-Diagnostics. Okay, this is a great software. I think it's great software anyway. And it has sort of like an easy mode as well. The easy mode allows you to just plan implants, it almost suggests the implants if it knows the implant that you actually work with, and allows you to, it plans it for you basically. I want to see if I can get back to that. We'll get that running. Okay. So as I said, consider the additional length of the drill tip. Due to construction function of the drills, the drill tip is a maximum of 0.4 millimeters longer than the implant insertion depth. The additional length must be taken into consideration during the planning phase. Just going back a moment to that co-diagnostics, I think we have that in all 3 parts of MSc, but also the boot camp. The whole point of the boot camp is that we're going to take all these principles, go over them, and then we're going to plan cases from start to finish together. And we'll do multiple type of cases that you're going to come up against, so that if you then just take record of those, you almost have got a kit for every case of how to plan it, what to charge, etc., etc. And just really going from there. We can go into that sort of at length. And the reason I like the easy mode for beginners is the fact that it plans for you. So what I usually ask people to do is plan it themselves and then put it into easy mode and see what it comes up with and compare your plan with the plan it has there. It's a great way of you finding out how to plan implants. Okay. Consider the coronal vertical implant position. This is also important. There's another reason that this is important because of emergence profile as well. A standard plus implant, this is a Straumann implant. These implants should be submerged. There's a collar of 1.8 millimeters that should be submerged. I'll go into why some implants I tend to submerge a little bit, not only because of the design, such as this one, but also because of emergence profile. Okay, risk assessment. After collecting the relevant information, patient history, after performing comprehensive clinical radiographic examination, studying models, assessing it and complexity, you need to see whether or not the case is for you. ITA, a wonderful institution, have basically introduced what's known as the SAC tool. You can download this, so please have a look for it. I'll have a look for you if you can't find it. And it allows you to classify your cases into simple, advanced, and complex. And it then gives you a scope, and you can see whether that's in your scope of practice, whether you need to refer out, and sometimes you can refer the case so that it isn't completed by the other clinician, but it can be made to be a simpler case. With a simpler case, so you started off with an advanced case and it becomes simple. And this is a great tool, simply because they're bone grafted or made the conditions from non-ideal to ideal. And it's free and it's available and easy to use. And it tells you whether a referral is appropriate. And it's not to harness referrals. We get lots of them anyway. It's simply to know when you should and when you shouldn't. And, I'm still a firm believer, and I still practice this. If in doubt, refer out. Okay, don't put yourself in that situation. I just want to show you this very quickly. This is a risk assessment, aesthetic risk assessment for the aesthetic zone. I just want to show you very quickly, again, we go through this in some of our other courses, particularly the boot camp again. This is sort of a larger thing to discuss. And what it does, it gives you a different score depending on different parameters, medical status, smoking, smile line, width of a dentulous span, tooth position, biotype, bioform, which is discussed. That's why I'm getting to look at things that way. Height of existing papilla, pocket depth, soft tissue health, bone zone, which we discussed, history of the site, whether it's tooth loss from trauma, infection, root canal, split root, aesthetic expectations. And it sort of puts a category into 1, 2, or 3, and it almost sort of tells you what to tell the patient. These forms sort of designed so you can actually put them in. It was designed by Stuart Harding. And it's a great tool to use if you're at that stage. Not a beginner stage, but it's a great thing to have a plan with while you're learning how to plan. So We also need a collar of keratinized tissue, at least 2 millimeters circumferentially to the implant, provides a protective cuff around the implant. Now, there's some papers recently that say that this is no longer the case and that you don't actually need 2 mils of keratinized tissue. I would still say that we stick to that. I've had problems with patients with mucosa around the implant, and it constantly causes irritation and problems, some of them ultimately ending in peri-implantitis. I would suggest we stick with keratinized tissue, and at a more advanced level, we can teach you how to, there's a soft tissue surgery rather than the bone and implant surgery, and we can teach you how to get keratinized tissue from either direct grafts or apically repositioning grafts, etc. So, you know, that's not really a problem. Okay, sorry, it seems to be jumping a little bit again, but we will plod on. And also it's less susceptible to recession. Okay, intraoral photographs, very important. They keep a record. We still take them, even though we have a few scanners at our practice, but it's still just as important because photographs are photographs. Scans are great, but they are different. Okay, and then your summary of considerations. Okay, for initial exams, single tooth gaps, healthy patient, good patient motivations, compliance, no active periodontitis, healed ridge, conventional loading protocol more than greater than 3 months. Okay, there's sufficient mesiodistal width of bone for the regular platforms or wide neck platforms, sufficient buccolingual buccopalatal bone width and height for placing implants without the need for bone augmentation, sufficient interocclusal distance for the prosthetic restoration, and minimal vertical oral opening space for 30 millimeters to allow surgical instruments, and also to check for any pathologic conditions such as caries or periapical problems or periodontitis. Okay. We will be putting most of this into the, well, not most of it, all of it into pack, but into a bit more of a comprehensive plan. I want you to have sheets that you can actually use, but then it's good to have little bullet point sheets with them so that you forget, oh, why is that important? What do I need to check there? There's no point in giving that and then you don't have any of the backing. And again, you can watch these lectures again and again on our YouTube channel. You have access to them. You don't need to be recording or trying things. They're all there for you. We're very transparent. We're happy to give you everything and give all of it away. This is a clinical exam sheet. This is a great sheet. I love this sheet. And we still use it almost, my nurses use it almost like a feedback mechanism. So things can't go wrong. When you might think, oh, well, look, he looks at that, he just gets on with that. No, we still have a step-by-step process, commonly known as a system. And look, it goes through the things you have to measure for that particular site. And I think it's great. We use it all the time. Okay. It has a separate part with the impressions, photographs, panoramic view, site specific, and X-ray template. Okay, finally, we're almost there. Emergence profile. Okay, let's just go back. The emergence profile is basically the tooth emerging from the implant and coming up to meet the adjacent teeth each side, mesial and distal, and the occlusal. So the reason this is important is that and as I said before, if I'm placing a narrow implant, I place it a bit deeper because to come from narrow to coming up to touching both sides and the top is you don't want that profile to suddenly shoot out and go up. So you've got this sort of lollipop or sort of oak tree shape. You want it to gradually come up. So you've got this lovely sort of paddle shape. Okay. And that's basically what the emergence is in a really basic form. It is a bit more, it's not particularly more complex than that, but we can get more complex. Clinical factors to take into consideration are the thickness of the gingiva in the area of implant placement. The thicker it is, you know, the more sort of liberty you have. The size of the horizontal cross-section of the future crown at the gingival level. So you need to see from the implant to how wide it needs to be at the gingival level, and the position of the future crown relative to the bone. Okay. Something from here, you can see it just shoots out. Had that been a little bit lower, we would have had probably a little bit of a smoother emergence profile, but not bad. Sometimes going too far the other way can also cause problems. in this situation? Would it have been better to have had a bone graft so that we can get the implant to the level so we have a crown that's comparable to the adjacent teeth and you don't end up with these triangles between and food packing? Okay. There you go. Straumann are great for this. They have the healing abutment, temporary restoration, and their final restoration using their abutments and tie bases, so that the healing abutment, temporary restoration, and final restoration are all consistent with their emergence profile. So that tissue settles to that, so that when you're actually going from a healing abutment to a temporary, it's not disturbing the tissue, it's maintaining and forming that tissue, so that when you fit the final restoration, it just slots in because the temporary restoration has prepared that tissue and cupped it for you so that it fits beautifully with the final restoration. Okay, platform switching. Platform switching is console platform switching refers to the use of a small diameter abutment on a larger diameter implant collar. This connection shifts the perimeter of the implant abutment junction, the IAJ, inward towards the center axis, i.e. the middle of the implant. What it means is if you've got a wide implant and the actual connection is in, so it usually has like a nice sort of shiny collar on top, and the actual neck of the implant for where you actually, the abutment goes in, is towards the center of the implant. This centralizes, as you said, the forces, so shifts the perimeter of the implant abutment junction inward towards the center. So you've got a central axis, and this is known to basically help with the loss of crestal bone loss, basically. The inflammatory infiltrate or peri-implant area, okay, the movements of crown and implant that can affect it, removal and replacement of prosthesis is taken on and off and on and off, and biological space for bone and tissue infill, because if you've got that bit that comes in, it allows space for bony infill and for tissue infill, creating a good seal and good neck at the top, good tissues, which significantly reduces the number one nemesis of implants, which is peri-implantitis. Okay, so that brings us to the end. I'll just quickly say, so look, I use the Straumann BLX implant. It comes in an SLA surface, which is amazing. It also comes in SLA active, which is osseointegrates fast and tend to use in compromised situations, or particularly where I'm grafting and placing at the same time. They're platforms, which, as you can see, that what I was talking about. And they're part of their rock solid implant group, which are much stronger than your average implant. I am just going to go through a couple of questions. Okay, let's have a look. Let's answer a few questions. So if you've got questions, please ask now. I'll try and answer as many as I can. What are some implants that seem easy but can end up hard for a new implant dentist? What ones should we try first and try last? As I said, I like the BLT. That's an implant I still use. The reason I like it, because it's not super aggressive, but aggressive enough for you to get good grip, as it were. Grip in dental or implant terms really means primary stability, and primary stability of the implant, is key. You know, if you get good primary stability, the likelihood of the implant being successful is extremely high. Okay. The reason I like the BLT implants is because you drill a hole. It's got a system for drilling the hole depending on the type of bone that you've got, and it's got a set system for each type of bone, so you can't go wrong because there's only 4 types, and it gives you a drilling protocol. We'll be going through that next time, and I probably will be talking more about the BLT next time, just because I think it's a great beginner implant. As I've been teaching and students have been using, I found that's the one that they seem to go, wow, you know, I finally solved it. I haven't got a million ways of restoring it, and I have to choose from these complex menus. It's a simple but quite flexible system, which is important. Okay, the implant goes down the hole that you drilled. End of story. The BLX tends to, it's a bit like a stallion. You have to sort of keep it in its place. It's much better in experienced hands. Okay, hi, please let me know what are the difference in terms of treatment planning for thick and thin biotypes. I think with the thick and thin biotypes, the first thing that jumps out, there are others, but without going to great group, I'll give you the basic, is usually in the aesthetic zone. So, you know, I want to know if someone's got a very thin biotype and a high smile line, I would be very careful as the type of surgery that I do or how invasive it is. I would probably spread out the stages somewhat so there's not too much trauma. So you've got to treat it almost delicately. I'd also probably want to try and my very best to get an ideal bone and height and tissue type before I place the implant. And I wouldn't be taking risks like placing implants and bone grafting and tissue grafting all at the same time. I would separate those out. So that's how I'd approach that. And that's okay. Bear with me. Sorry, there's a few more coming in. Okay, what two should we start? I'm just going to do one more, and then anybody else who's asked questions, I'm sorry, just please do contact me. I'm happy to discuss things. Two more. What tooth should we start replacing when we first start? I think premolars are usually quite a good one to do, probably upper premolars, because the lower premolars tend to be in the region of the mental foramen and mental nerve. I usually also suggest that you don't go for immediate replacements, that you have a delayed approach, and that you also have a delayed approach in restoring the implants as well. Delayed loading. So delayed process placement and delayed loading as well. In those cases, I would prefer you to place the implant, get a decent torque, put a cover screw on it, stitch it over and bury it and let it sleep and let it integrate. Come back to it, then you can expose it and check it and then move forward from there. And that's the way I'd approach that. Boot camp, when is it, how much is it? Okay, we discussed this last time. The boot camp we're doing for a ridiculously low fee. I usually charge roughly about $3,500 for a 2-day course. We're not charging that at all. We're doing a 2-day course for $595, and it's only $300 if you bring a friend, because it's 2 for the price of 1. So you pay $595 and you can find a friend to bring with you. It's half each. That's 12 hours CPD, and we will be going extensively through the first part of this, everything you need to then get started. And anybody entering that and getting themselves involved with the group and involved with the boot camp will then have ongoing mentorship. It's not just a case you come to boot camp and pay for it or whatever it may be. The whole purpose of that is just to cover the cost of running it, and that's why we've kept it minimal. We're not sort of looking anything beyond that, and for you to get started and also for you to build relationships so that you can not only work with your colleagues, but with me, so that you can get ongoing mentorship and advice so that it keeps you safe and you can start really getting excited and enjoying implant dentistry. And that's really it. Look, as I said before, if you'd like to get into the practice, you'd like to get in contact with us, please do. We'd love to see you. Please do it by email. We've had a bunch of people and we're already booking up sessions where they'd like to assist in things. And some of the people coming in are complete novices and want to assist in quite complex things. Just want to see, what can be done. I'm happy for you to come along. Thank you ever so much for listening. Please do remember to fill in your feedback form so you get your CPD. Please do get your friends and colleagues to follow. If we send a link or you see the ad for it, please share it. Share it to a group. I'm happy for you to share it everywhere. As I said, we're trying to build a sort of honest, transparent, and collaborative community. And I very much look forward to seeing you next time. And the next webinar will be just as exciting. So take care till then, and I'll see you then. Bye-bye now.